All right, it is my pleasure today to introduce Dr. Ashwin Kamath. He developed a keen interest in neuroscience and an appreciation for the technical art of surgery while in medical school. As a fellowship-trained neurosurgeon, he finds immense personal satisfaction in caring for patients with brain and spine conditions and seeing them do well. He believes in a personalized approach where patients are educated on their condition, informed about their choices, and treated like family. Outside of the hospital, he enjoys reading, fitness, triathlons, and spending time with his family and rescue dog. He is a provider who is practicing as a member of the Baylor Scott and White NeuroHealth Institute, as well as on the medical staff of Neuro Texas. Dr. Kamath, I will hand it over to you.
Okay, great. Yeah, thank you, Kathy. Hopefully you all can see me and hear me clearly. If you can't, please let us know now. And then, Kathy, I have one question for you before we start. Are you able to see my mouse pointer
I
here?
am. I can see it.
You can see it. Okay, perfect.
Yes.
'Cause, I
Yes.
might point out a few things on the slides as we go along. And if I do this, are you seeing any change in the presentation right now?
It's just kind of refocusing when you do that. It's
Okay,
almost like a little blip.
got it. Okay. And how about now? Can you see my mouse here?
Yes.
You can.
Yes.
Okay, great.
Yes.
Okay, perfect. Well, yes, thank you again, and welcome everybody. I'm Ashwin Kamath. As Kathy mentioned, I'm a neurosurgeon, and I practice both brain and spine surgery. But I hope to talk to you today about back and neck pain, which relates to the spine, and which is probably one of the most common things that we treat in my field. And so I hope this is helpful. And yes, please ask questions. I want to be mindful of time and make sure that we have enough time to answer everybody's questions at the end. Okay. Let's see here. So this is what I'm going to go over today. So we'll talk about the problem, which is spinal pain. And spinal pain includes back and neck pain. I'm going to show you that this is one of the most common and serious public health problems in the US and worldwide. We'll talk about some of the causes of spinal pain, of which there are many. And then we'll go over some basic anatomy so you can understand what's actually going on in the spine. And then we'll talk about how we treat issues in the spine, both non-surgical and surgical. All right, so if this was a live audience, I would be asking for a show of hands for how many in the audience have ever had low back or neck pain that's more than just, everyday minor aches and pains. And I'd be willing to bet that many of you, or maybe most of you, would raise your hand because this is a big problem that the majority of people get in their lifetimes. So back and neck pain accounts for about 40 to 50% of all pain experienced by adults in the US. And over 1 in 4 US adults has experienced back or neck pain in the past 3 months. And like I said, this is really a global problem. In the year 2020, low back pain affected 600 million people globally. And it's estimated to cause over $28 billion in lost productivity in the US alone. Most of this loss is due to disability or decreased productivity, as well as work absenteeism. And then back pain is actually the second biggest cause of work absenteeism. The first is actually headaches. But spinal pain is obviously a huge issue. And then by the year 2050, the number of people affected by back pain is projected to increase quite a bit from over 600 million people today around the globe to over 800 million people by the year 2050. And most of this is driven by an expanding population and aging. People are living longer, aging, getting older and older. And we also have more and more people hunching over screens, working virtually, using their phones, et cetera, which is, definitely a contributor to the problem. Back and neck pain are some of the most common initial complaints that are seen at primary care doctors, as well as emergency rooms around the world. So it's definitely an issue that I'm sure has affected many of you listening today. So what are some of the causes of back and neck pain? And I'll just preface this by saying there are many. And what I'm about to show you is not a full list, but it's it's a big overview of what can cause pain. So these are some of the most common causes of pain. So I'm going to go from roughly most common to least common here. So trauma, of course, sprains, strains, whiplash injuries, fractures, sports injuries. These are very common in everybody, younger people, athletes, older folks who have falls, car accidents, really can affect anybody at any age in their life. Degenerative conditions. So when we talk about slipped discs or bone spurs or spinal stenosis, stenosis just means narrowing. Those generally refer to degenerative changes. And you might hear the term arthritis, you might hear the phrase wear and tear. They all mean basically the same thing, that as we get older and our spines get older, that gravity, and weight tends to take its toll on our spine. And you can develop disc problems, disc herniations, bone spurs, things like that. I'm going to show you some pictures of that coming up here very soon. Posture, posture is obviously a big issue, especially with today with, screens and everything that we use daily. Pregnancy, of course, can affect the spine in many ways, occupational issues. Now, here's some more causes of back pain. So you can have inflammatory causes of back pain, such as rheumatoid arthritis, ankylosing spondylitis, and other conditions. You can have infectious causes of back pain, so discitis or osteomyelitis are the names for those. Oncologic, of course, cancer can spread to the bones, including the spine, and that can cause quite a bit of pain and disability. And then metabolic issues such as osteoporosis, calcium and vitamin D deficiencies, which can lead to compression fractures and lead to pain. And then you also have these causes of spine pain. Again, we're going roughly from most common to less common. But there are some congenital issues, issues that you're born with that can cause spinal pain. Sometimes spine pain can be caused by not a spinal problem at all. You can have biliary problems, gallbladder issues, liver issues involving other organs that can present as back pain. And then, of course, anxiety and stress is always something that can contribute to back pain, as many of us are well aware. Most of the problems in the spine occur either in the neck or the cervical spine or the low back, lumbar spine. Now remember that there's three broad regions of the spine. There's the neck or the cervical spine. There's the mid-back or the thoracic spine, and there's the low back or the lumbar spine. The neck and low back are most commonly affected because they bear a lot of weight. Your neck bears the weight of your head, which is constantly moving. And your low back bears the weight of everything above your waist. And so that is particularly a pressure point in the spine. And so those two regions bear a lot of weight, and they're also the most mobile parts of the spine. You can move your neck around a lot, you can move your low back around a lot, but you can't really move your mid back around a lot. Part of the reason for that is that the rib cage is stabilizing for the mid back. And so all those issues I just mentioned, they can happen in the thoracic spine, in the mid spine. We see that from time to time, but by and large, most of the issues are in the neck or in the low back for those reasons. I want to talk about some anatomy a little bit, and I don't want to get too far into the weeds with this, but just to show you, and hopefully you can see my mouse here. So this is the neck, okay, and this is the front of the neck this way and the back this way. So it's as though we're looking at it with somebody facing to the left. There are 7 bones in the cervical spine called C1 all the way at the top. That's the one that attaches to the skull. And C7 all the way at the bottom, which attaches to T1, which is the first vertebrae of the mid-back. And that's where the first rib attaches. So C1 to C7. And there's a lot of different parts of the spine. As you can see, it's a complex structure. There's the vertebrae, which is each bone stacked one on top of the other. There are the discs, which are these little blue parts in between the bones. And the disc acts like a shock absorber between the bones. It's kind of like this rubbery, joint between the bones. There's some movement, not a lot, but there's a little bit of movement that can occur at the disc. And so you can imagine that after a lifetime, of movement, that sometimes these discs can kind of extrude or get bigger or kind of bulge out, which I'll show some pictures of. There are several joints in the spine called the facet joints. Those are these joints back here in the back of the spine,
Excuse me.
which which attach the vertebrae together. There's the
Excuse
spinal
me.
cord. Oh, was there a question?
Yeah, I think your mouse, for my view, the mouse is offset from where you're trying to point to the picture, which is on the right. I'm seeing the mouse over on the left half of the slide. I don't know why. Yeah, there. Well,
Am I
now you're on the
pointing
word
to
front.
Am I pointing to front right now?
Yeah, now you
Yes.
are.
Got it.
Thank you.
Okay, no problem. So
Thank you.
I'll use this view. Yep, thank you for pointing that out. So let me go over that real quick again. So these are the vertebrae here. These are the bones that are stacked one on top of the other. In between the vertebrae are these little blue areas. Those are the discs. In the back of the spine, there's these smaller joints called the facet joints. And then we have the spinal cord, which is this yellow structure. And you can see through part of it here. And down here, it goes through a tunnel in the bone called the spinal canal. And then at each vertebrae, there are these nerves that come out. They come off the spinal cord and they come out and they go to the periphery. They go to your arms, your abdomen, chest and abdomen, and they go down your legs. And here's what it looks like when a disc is bulging. You can see that these nerves come out of these little windows in the bone to go off to wherever they're going to go. And when you have a disc bulge, it can pinch off that little window and cause pressure on that nerve. And that can cause a number of symptoms. It can cause pain, it can cause numbness, tingling, weakness, or a few other symptoms that we look for. But most commonly, pain. This is a painful thing. And that applies to the neck as well as the low back. Here is what it looks like with a normal neck, which is similar to the one I just showed you. And here on the right is what it looks like when there's degeneration. You can see bone spurs, which are these little spikes that happen, that occur over time. You can see collapse of the disc space here. So, they're not nice and plump anymore. They can collapse down. And you can also see bulges, like I showed on the previous slide. Now, these can all occur, at the same time, or they can occur just one at a time. So they can be diffuse throughout the spine, or they can be focal. But we know that as time goes on and as spines age, that these tend to be diffuse issues that can happen all throughout the spine. So I usually tell folks, if you're above the age of 40 or 50, you're going to have some degree of degeneration in your spine. Some people degenerate more than others. Some people don't, but almost everybody above the age of 40 or 50, if you get an MRI on their spine, you're going to see some degree of degeneration. So it's really a normal process of aging and wear and tear that happens. So I'm going to go over a little bit of imaging so that, these are the pictures that I show patients in the office when they come to me. So this is a normal cervical spine MRI of the neck. I would guess that this is a fairly young person. This is the front of the head, the front of the neck, and here's the back of the head and back of the neck. So the person is, again, facing to the left here. You can see the vertebrae here, stacked one on top of the other. You can see the discs, which are those shock absorbers between the vertebrae. And you can see this gray stripe here. That's the spinal cord. And the spinal cord runs in this tunnel called the spinal canal. And the white part in front of and in back of the spinal cord is spinal fluid, or CSF. So normally the spine is floating nice and free in this canal. Okay, and there's not really much going on here. This is a very healthy looking spine. You can maybe see just a touch of degeneration starting at these two discs here, just a little bulge, but really nothing to speak of. This is essentially a normal scan. Now you can contrast that to this one here, where you can see a focal problem. There's a disc bulge here that is pinching on the spinal cord. Okay, and so this is what we call a slip disc or a herniated disc. And I would predict that this would cause pain or numbness or weakness down this person's arm. Now it gets even more specific than that. Based on the level it's at, this is a C5, C6 disc, we can kind of predict where in the arm this pain is going to go, or where their symptoms are going to be. And so that's one thing about the spine, is that we're always correlating what we see on the picture to what you're telling us, what the patient is telling us. And those two things need to match up. But this gives you an idea of what a herniated disc looks like. And this is a fairly severe one, I would say. Here is another picture of multi-level degeneration, and you can get a sense here about the spinal cord getting really squeezed at a few levels. This is 1, 2, 3 levels. And something to note here is that within the spinal cord, right where my mouse is, hopefully it's at the right spot now, you can see a little bit of white in the spinal cord, and that is inflammation and swelling within the spinal cord that happens when there's severe pinching of the cord. And so that's really an issue. This is somebody who, if they came into my office, I'd be recommending surgery pretty strongly for this. If something like this is not treated, it can cause worsening pain and disability. And so this is a relatively severe case. And then this is the anatomy of the low back. And you can see it's very similar to the anatomy of the neck. These are the lumbar vertebrae, once again, stacked on top of each one of the other, L4, L5, and this is S1, or the first bone of the pelvis. In between those bones are the discs, once again, and then nerves coming out in these little tunnels here. And then this is just another view of the same thing from the back. And once again, we have a normal spine as well as a herniated disc, and you can see how that pinches the nerve coming out. One important thing to note is, a lot of people look at their MRI reports and they say, well, I have a bulging disc at L4-5, so it should hurt right where L4-5 is, right? That's not always the case. Sometimes yes, but if you have a pinched disc at L4-5, it's going to hurt down your leg, most likely. They might hurt in your back too, but remember, these nerves all run down the arms and legs, and that's where it's going to hurt. And that's normally what we're looking for. You can see on the right side here, normal disc, and here's all the bad things that can happen to discs. It's usually some combination of all of these that are happening at the same time. And then here's an MRI of the low back. Again, this is a pretty normal looking MRI. There's nothing to note here. This is the same thing. The patient's looking off to the left side. Here's the back of the spine. Here's towards the front. You can see the bones, and then in the low back, you can see the spinal cord here, and the spinal cord actually ends, it kind of tapers off at about L1, L2. And below that, it kind of turns into spaghetti, and the spaghetti are the nerves. And these are the nerves that continue in the spinal canal, and they exit the spinal canal at various points up and down. And they go down to the pelvis, the groin and buttocks area, and the legs to innervate those parts of the body. Now, here's a picture on the right side of a disc herniation, and you can probably already see the problem right here. That L5S1, this is a pretty large disc herniation that almost pinches off the entire spinal canal. So I would expect this person to be having pretty bad leg pain down one or both of the legs, as well as possibly some back pain. And just like in the neck, this can happen at multiple levels. And so here you see multiple levels where these arrows are of degeneration, where that spinal canal is pinched off. Sometimes we can have other problems in the back, like instability. And you can see here that one of the vertebrae is slipped on top of the other one. They're not aligned. This is, a significant slip, and this can cause back pain in particular, as well as leg pain. We're always looking at that distinction between back and leg pain. And instability is one of those problems that we can treat and we can fix with various methods or with surgery. But this tends to cause back pain in addition to leg pain pretty badly. All right, so why might somebody have back or leg pain, but their doctor says the MRI looks okay? Well, there's many reasons for spine pain that cannot be seen on imaging. And so the spine is a complicated structure, and there's lots of different parts to it. There's bones, there's joints, as we went over. There's also ligaments, there's tendons, there's muscles, and there's nerves. And so any one of these can hurt. Sometimes there are structural problems that can affect them. Sometimes it's not a structural problem. It's something like inflammation, or it's something like a sick nerve itself. It's not being pinched, but it hurts. And so the point of this is to say that we can't always tell based on an MRI whether somebody's having back or neck pain. So there are some people out there with MRIs that look perfectly normal that have really bad pain for other reasons. And on the converse side, there are people with really bad looking MRIs who have little or no pain. And so the picture is just one part of the problem that we take together with everything else to determine what is the cause of the pain and what is the treatment that would most benefit. So here's just a small example of how complicated the spine is. And these are diagrams that are studied in medical school. But there's all kinds of things going on here. And any one of these parts can hurt. So this is just to give you an idea of the complexity of the structure. All right, so what are some signs of a pinched nerve? And I kind of alluded to this before, but pain is number one, and is the most common one. And specifically, remember, not pain in the spine, or not pain just in the spine, but pain that goes somewhere else. It goes down an arm or a leg. It shoots down into the hand. It shoots down into the fingers, or it shoots down into the foot and involves the calf or the toes. That is the hallmark of a pinched nerve. Now, it's not always painful. You can have a pinched nerve and have other symptoms too, but most commonly, it's going to hurt. Numbness is a big one. Weakness. So you can have muscle weakness. So, folks with compression in their neck often say that they feel like their hands are weak, like their fingers are numb and tingly, and they have trouble holding a cup or writing with a pencil or buttoning buttons. So difficulty with fine motor tasks is a sign of a pinched nerve or a pinched spinal cord in the neck. Foot drop. If you can see this picture down here, this is somebody with a foot drop, and this person is being asked to point their toes up towards their nose. And you can see that they're doing it on the left side, but their right side is not able to come up like that. And that's part of weakness that can be caused by a pinched nerve in the back, in the low back. Tingling or pins and needles, also very common. I will say also that tingling, pins and needles, and numbness can all happen after a pinched nerve is unpinched too. So when we do surgery for a pinched nerve, people are experiencing a lot of these symptoms, but I always tell folks sometimes after we relieve that pressure, you can get numbness and tingling and pins and needles for a period of time. And it's almost always temporary, it goes away. But it's just like when you fall asleep on your arm and your arm goes kind of numb for a little while. And then when you wake up and the pressure comes off, when those nerves are waking up again, they start firing in all kinds of strange ways. And you can feel tingling, pins and needles. You can feel hot, cold sensations as that extremity is waking up and as those nerves are waking up. So that can be caused by a pinched nerve as well as a newly unpinched nerve, if that makes sense. Heaviness is another one, a feeling of heaviness or fullness of the extremity, or a feeling that you need to make an extra effort to lift that arm or lift that leg up. And difficulty with fine motor skills that we talked about. When should you get help quickly? If any of these things are sudden onset. So timing is key. So I always ask people, how long have you had this problem? If you have pain and numbness in your arm for 5 years, it's very different than if you have pain and numbness in your arms for 5 days or 5 hours. And so the time really makes a difference in how we manage it. So if any of these things come on suddenly, seek help. New bowel or bladder incontinence. This is definitely an issue that needs to be evaluated. If you have an acutely pinched nerve in your back, it can result in a condition with incontinence because those nerves go to the pelvis, as I mentioned. And if you're newly incontinent, that's an issue to be looked at. It's important to note here that there are a few different kinds of incontinence. There's stress incontinence and urge incontinence where you feel it coming, but you can't get to the bathroom in time. The most concerning type of incontinence is where you don't even know that you're going to the bathroom and you look down and you've gone to the bathroom without even knowing it. So if that happens, that's an issue that should be looked at fairly urgently. And I'll also say that there may be other causes of that are not from the spine, but any ER or doctor that you go to, if you tell them incontinence, the first thing they're going to be thinking about is this a spine issue that's come up suddenly? And then gait instability or balance issues. Just like the other one, there's a lot of different problems that can cause gait instability or balance issues. The concerning one, or one of the concerning ones, at least the one I'm concerned about, is a compression of the spinal cord. And gait or balance problems can be caused by compression in the low back, but it can also be caused by compression in the neck. Because remember that the spinal cord from the neck runs all the way down to the rest of the body. So if you have a pinched spinal cord in the neck, that can sometimes manifest as problems with gait or balance, affecting the whole rest of the body. So these are things that have a number of different causes, but we're always looking to make sure that it's not related to the spine. So this is the clinical protocol. There's two main things that I'm looking at when somebody comes into my office and tells me they have any number of these issues. I'm talking about how does it feel, where does the pain go, what are the features of the pain or the discomfort or the whatever symptom they're having, how long has it been going on for, and all of the above, right? And I'm trying to match that up with how does it look on imaging. Each one of these is just information. We can't take one thing and make a diagnosis. We have to put them together. So what I'm trying to do is see, is there concordance? Is there agreement between how you feel and how it looks on the scan? And if there isn't, that doesn't mean that you shouldn't be having pain, because remember, there's a lot of things that can cause neck and back pain that we can't see on an MRI. But the things that we can see on an MRI or on a CAT scan, those are the things that we can fix with surgery. And that's, as a surgeon, that's primarily what I'm looking for. And so when those things agree, when the distribution and nature of the pain agrees with what I'm seeing on the imaging, that's when we start thinking, okay, maybe surgery can help because there's a structural problem and it's causing the expected symptom. And so that's something that we can talk about fixing with surgery or with other means. But first, before we talk about surgery, we always think about non-surgical options. So what if you can't have surgery, or what if you don't want surgery, or what if it's just too early for surgery? The majority of people who I see in clinic are not candidates for surgery. And that's because surgery is a last resort. And you're going to see on this slide, there's a lot of different things that we do before we consider surgery, except in severe situations. So time, a large part of back and neck pain, especially if it's related to sprains and strains, whiplash injuries, which are very common, can get better with some time and rest. Of course, that doesn't always work, but for many cases, it does. Weight loss, I put this one early and I also bolded it because it's more and more significant problem in our society today. Weight loss in general is good for your overall health, but is also particularly good for your spine health. Because as you can imagine, the spine is a vertical structure, and the more weight you have, the more wear and tear, and the faster things progress in the spine. And so, weight loss is a big part of it for some folks. Exercise, exercise involves strengthening of the musculature around the spine, especially core exercises can help with that. They can help stabilize in cases where there's instability. And physical therapy can also help with that. Massage therapy, and of course, many people have done many of these things before they come to me, but occasionally I get people who come to me without having tried many of these, and that's why I'm putting them up here. Chiropractor. Chiropractors is a little bit of a double-edged sword. There are certainly chiropractors that work and that do good work and help people with these issues. Sometimes chiropractors also do manipulations of the back and neck, and occasionally I see people in whom that's actually made the problem worse or precipitated a problem. Now that's not a knock on chiropractors. They, again, many of them do good work and do truly help people with these conditions, but and often people have already gone to one before they see me. Heat and cold therapy. People are always asking me which one is better, and the answer is it just depends on what works for you. I found that people tend to like heating pads applied to the back or neck. That can help, especially if the pain involves the muscles, which often it does. Acupuncture. Now, I don't usually formally recommend acupuncture, but just anecdotally, a lot of people swear by it. Not everybody, but for many people, it seems to work, and we don't really understand why, but it does. And so that's also a consideration. Lifestyle or ergonomic changes. I'm straightening up my back myself as I read that. But having good posture, if you work on a computer all day, having the keyboard and the screen at a good position, investing in a standing desk, things like that can make a big difference. Of course, yoga or Pilates kind of groups in with exercise. And then there's a whole host of gadgets that are out there to help people with back and neck pain. TENS units, inversion tables, traction therapy at home. These all can work, and there's not one that's better or worse than the others. You just have to try them and see what works for you. And then medications, of course, over-the-counter, common things, Tylenol, Advil, Motrin. The majority of back and neck pain actually responds well to these, especially in the early stages. So this is a long list. A lot of people try a lot of these things. There's entire industries built around these interventions, and for good reason, because a lot of back pain does respond to these measures. Now, what if it doesn't? So for people who have more severe pain or persistent pain, here are the main options that I'm thinking of before we talk about surgery. The first is physical therapy. Physical therapy is helpful because it's a qualified professional who's doing the exercises with you, looking at your form and getting you on a program to do the exercises at home the right way. And these exercises, they don't fix the structural issues in the spine. They won't fix a herniated disc. They won't fix instability, but they will help strengthen your muscles and strengthen the core to prevent these things from progressing. And sometimes they do work very well to reduce or eliminate pain. And so oftentimes I'm looking to patients to see, have you had physical therapy before, specifically targeted to your neck or back? Pain management. So pain management doctors, we partner with them a lot because they don't just do medications. I'm going to talk about this in a second, but they are well qualified, many of them, to help alleviate pain if surgery is not on the table. And then other specialties, depending on what the problem is. So physiatry or physical medicine and rehabilitation, rheumatology for certain conditions, neurology for certain conditions, and orthopedics. Again, all depending on the problem. So pain management. Most people say, well, I don't just want pain pills to mask the pain. And yes, that is a valid concern. But I usually remind folks that there are a lot of medication options for pain. It's not just opiates. There's a lot of different classes of medications. NSAIDs are drugs like aspirin and ibuprofen. There's medications specifically for nerve pain, for special kinds of pain like neuropathic pain. There are muscle relaxers, there are antidepressants, and of course there are opioids for people who do need them, and there are folks who do truly need opioids because the pain can be severe. And then other medications like Tylenol, for example, is one that doesn't fit into any of these categories. But there's a lot of medications that fall into that other category. So my point with this slide is to say that if you go to get pain management, you're not just going to get opioids. There's a whole host of medications that can and do help people significantly with pain. And it's usually worth trying one or more of these, before we start talking about surgery. And by the time they get to me, most people have tried one or several of these medications. Pain management doctors also do procedures for pain. These are not really surgeries. They're usually in-office procedures, such as injections. They can also do ablations or anesthetic blocks and a few other ones that are usually just done in the office, and that can help the pain. But once again, these, just like medications and PT, these don't help the structural issues in the spine. They don't reverse a herniated disc, but they can relieve symptoms. So they can put the nerves to sleep, they can relieve inflammation, they can result in good relief of symptoms, sometimes for months, sometimes for only a few days or a few weeks. It all depends. Now, I'd like to talk about surgery, and I want to go over this, in a little bit of detail, but being mindful of time here. But the main goals of surgery that we look at, there's not many of them. There's a few depending on the situation. One of the most common goals of surgery is decompression. So if you look at this image on the left, you can see, you guys are all experts at imaging now, right? So this is a lumbar spine MRI. There's a big herniated disc here at L4, L5 in the lower spine. This is a very large herniated disc. And so we'd almost always be recommending surgery for something this severe. And the surgery would be a decompression. So the point of that is just to relieve the pressure on the nerve and to fix that part, and that's it. Occasionally, we do have to perform a fusion in the spine, and this is an example of that on the right. So you can see that's the same spot as the other picture. This is L4-5, but this disc space is quite collapsed and sclerotic, and you can see some inflammation. That's the white stuff here in the vertebrae above and below it. And so this can certainly be causing pain. Now, we can't just go in and take out the disc and leave nothing there, because then that would cause instability. And in those cases, sometimes we put a little spacer in here and we do a fusion where we connect the bones above and below in the hopes that over time, those bones will grow together into one. Now, we try to avoid a fusion, of course, whenever possible, but in some cases, it's really the only good option. And thankfully, I'll go over this in some detail again in the next slide, I think. But thankfully, the techniques that we use for surgery have improved quite a bit these days, to the point where we can do these surgeries fairly safely and predictably. And then another goal of surgery is to restore alignment. So remember that when I showed you where there was a slip between the two vertebrae, we would have the goal of restoring the alignment of the spine, which most of the time also requires a fusion. Just a little note here that neurosurgeons and orthopedic surgeons perform spine surgery. Both are qualified. I would say the only difference is that neurosurgeons usually spend a bit more time in training to do spine surgery, and also that neurosurgeons can do spine surgery that involves the spinal cord itself or the nerve roots themselves. And that's not a knock on orthopedic surgeons. They there are certainly ones that do good work and are very well trained. And so we just have some overlap in our fields, but neurosurgeons tend to do surgery involving the spine as well as the nerves and spinal cord, if that's needed. So surgery is a scary thing, and it's with good reason. In the 70s and before, 70s, 80s, these cases used to be really big ones. They would involve large incisions. They would involve long hospital stays. This is called a Minerva jacket. This was an old treatment for spine injuries. And people would be immobilized for days or weeks or more of just bed rest in the hospital. They would get complications like pneumonias and bed sores and things like that. Thankfully, we don't really do these anymore at all. In fact, in all my training, I have not seen one of these casts at all. And this is something called a halo vest. I've seen this maybe a small handful of times for some very special situations, but not really much anymore. So spine surgery has come a very long way since those days. We have better imaging of the spine. We have better visualization of the spine. So we do a lot of our cases through microscopes or endoscopes now. Our instruments are much better. Our techniques that we use in surgery are much better. And these have now been validated by large-scale trials, involving hundreds or thousands of patients around the world. So we have a much better understanding now of what works and what doesn't work in the spine. And finally, there's better technology. So on the left side here, you can see this is a computer screen that's showing a CAT scan of the spine in real time. So these days, we use this computer where we can point an instrument to somebody's spine who's asleep on the table, and we can directly see on the CAT scan where we're going. And it's a really remarkable thing. It's not just shooting a bunch of X-rays. It's a real-time image, and we use this computer assistance routinely now in surgery. I use it routinely on certain cases. And so this is more like what we're looking like in the OR these days. And as a result of all of that, spine surgery now takes place with smaller incisions, with less blood loss, less surgery time, and faster recovery time, and less time in the hospital, which is great. So just to give you an idea, this case that I'm showing you here, this can be done with a surgery about this big, with this big of an incision. And I would say 90 to 95% of people go home the same day from something like this. This is one of the most common procedures that we do. Of course, sometimes people need to stay longer in the hospital, but I'd say for the majority of our cases, it's it's either a same day or a couple of days in the hospital and then home. And so it's very different than it was a few decades ago. So I'm going to finish up here and hopefully have some time for questions. So back and neck pain is very common. It's a major public health problem. The spine is complicated. There's many reasons for pain in the spine, in the back and neck that we don't fully understand. And sometimes we can't point to something that causes pain, but sometimes we can. And those are the cases that usually we can help with surgery. There are many treatments for back and neck pain that don't involve surgery, thankfully. And then surgery is reserved for specific issues that have a clear structural cause. So again, if the symptoms and the imaging lines up and there's a structural issue, those are the folks who I'm saying, okay, we can probably start a conversation about surgery to help your pain. And then surgery has improved tremendously in the past few decades to the point where most of the cases that we do are quite safe and predictable. And that's obviously a discussion that I have with anybody who does end up needing surgery. All right, so again, my name is Ashwin Kamath. I'm a neurosurgeon here with Baylor Scott & White and the Neurotexas group. There's a website here with my information on it. That's my office number. And yeah, we have about 10 or 12 minutes left, so be happy to answer any questions from the audience. Hope this helped.
It doesn't look like there were any questions placed into the chat. I do have one. What is your view on cupping?
It's a little bit plus minus. I would say it kind of falls into the category of things like acupuncture and needling, where Many folks find that there is a benefit to it. We don't exactly know why it works or how it works, but it seems to help some people. And that's pretty much the best we can say at this point. I don't think it's dangerous. Like acupuncture, it's fairly low risk. And so for people who are interested or willing to give it a try, it's certainly worth a try. Um, you know, if you feel comfortable with your provider and all of that, but it's not something I usually formally recommend.
Okay, thank you. Let's see.
I asked one.
Okay, I'm looking at that right now, Jim. Surgery is expensive and you outlined several non-surgical options, but why is it so hard for insurance to cover those much cheaper options?
That's a great question. When it comes to insurance companies and actually paying for treatments, I could probably have a whole other talk on that topic. The best answer I have is, it depends based on the insurance. And, insurance generally is, it's something that we deal with all the time. Every day, I would say we deal with insurance to find out about why some things are paid for and why some are not. You know, ultimately, it's really just a case by case scenario. Every insurance is different. It's a reality of the healthcare system that we have, that we do spend a lot of time, myself personally too, talking to insurance companies and trying to get them to pay for things. And which they do in most of the time, but the times that they don't, it can be difficult. And I don't have a great answer for how to fix that, unfortunately, but it's an issue. Yeah.
And I'll just share with everybody, Dr. Kamath, you probably are aware of this. Medicare has started covering acupuncture treatments for lower back pain within the last year or so. So, and I only know this because I have an elderly dad who went to Neurotexas, had some spine surgery, but he's still getting some pain now and then. But his PCP just put it in order for the acupuncture, and he's finishing up. I think he got 12 sessions that they'll cover, the insurance will cover. So that's just another option that's out there available for folks. Okay, let's see. Do you ever associate inflammation to diet and or genetic factors?
Certainly. I mean, that's a great question. There is a connection there for both diet and genetics. We don't really know or understand what that is yet. There are certain conditions, like genetic conditions, where it's clear, people with autoimmune diseases, rheumatoid arthritis, things like that, lupus. Those are people in whom their immune system has a dysfunction of some kind. Their immune system has an issue. But other than that, we don't really know. The immune system is a very complicated thing, and we know that diet and genetics plays a role. We don't really know to what extent or how to fix that. There's a lot of research going on about the gut-brain axis and the gut immune axis now, and we're only starting the beginning to understand that.
Okay, another question. What happens to the bulging disc when surgery is an option? Does it go away or deflate?
Yeah, that's a great question too. So when we take out a bulging disc, like that example that I showed, we are just taking out the part of the disc that is bulging or pinching on the nerve. In those cases, we don't take out the whole disc. We just take out the part that is pinching on the nerve. And that usually ends up being probably 10% of the whole disc. So we actually physically take it out, and the rest of the disc just remains in place as it should be. Now, in some cases, like that severely collapsed disc I showed you, in some cases, we do have to go in and take out the whole disc and put a spacer where that disc used to be. But if we're just doing a decompression, we're just taking out the little piece that's pinching on the nerve.
Okay, great. Dr. Kamath, can you explain the affiliation of Neurotexas with Baylor Scott and White so folks understand?
Yeah, of course. I know that can be confusing. So Neurotexas is an independent practice, but we are very closely affiliated with Baylor Scott and White. So we operate out of Baylor Scott and White clinics. We do cases in Baylor Scott and White hospitals. Strictly speaking, on paper, we are an independent practice, but we work very, very closely together. So.
Great. And another question, could you address ultrasonic surgery?
Yeah, so that I would say is a fairly general term. There's a lot of different technologies out there, things like lasers, laser surgery, ultrasonic surgery. We have tools in the OR that we use that use ultrasonic waves to take out things like tumors or pieces of disc and things like that. So we have some tools that use ultrasound and ultrasonic technology, but that's basically it. There isn't really a field as far as I'm aware, there's not a subset of surgery called ultrasonic surgery. But we do use that technology in the OR from time to time.
Okay, great. All right. Any other questions before we let Dr. Kamath grab hopefully a quick lunch before he heads back to clinic? All right, I'm not seeing anything coming in.
Thank you very much.
Thank you all for
Yeah.
joining. And
Yes.
again, I will be sending out a very short email following up. And thank you, Dr. Kamath, for the great information.
Of course, yeah, it's been a pleasure. Thank you all for listening, and please feel free to get in touch with me or my office if I can help you in any way. And pleasure to be here today.
Thank you all. Have a great afternoon.
Thank you.